Hello, my baby. Hello, my darling. Hello, my ragtime gal. You ask yourself, why is he torturing us with singing like that? Well, it's to distract from my hair. Boom, boom. Anyway, my name is Mitch Taylor, and I'll be talking about ECG monitoring and treatments. We'll talk about some of the objectives. We'll talk about chemistry. We'll talk about what's going on. Then we'll get into rhythm recognition and interpretation. And we'll move ahead, and we're going to do a kind of a Facebook type look to it. We'll see what you think of that, and you can let me know. Thank you. Okay, the kind of the health book look to it, I kind of want to explain this a little bit. It kind of looks like a Facebook, so it looks like the ECG's posting, and have a thumbs up and share, and there'll be another post from, like, in this particular picture, the NANDA, and on the left hand column there'll be little tidbits of information. In this case, it's the relevance. Why are we teaching this content? And on other slides, it may be key points, or try and maybe give you some information that might help you clinically, or might reinforce some concepts. So if you're familiar with Cornell notes, it's kind of like that. On the left column is you're kind of hitting key points, or giving you a chance to kind of reflect on key concepts. So these are the objectives or our outcomes, and following completion of the activities, the student should be able to analyze comprehensive data. So we're going to collect a bunch of data here from the patient, from labs, from the rhythm itself. We'll look at all of that stuff and analyze it for the patient that has rhythms that are too fast, too slow, and dead. We'll take individualized care plans, and we'll develop them based on the patient's values, clinical expertise, and evidence, and make safe and effective judgments. So nursing diagnosis NANDA pops up and says, hey, don't forget about me, and posts, these will be the nursing diagnosis you look at first. There could be others, but these will be the first ones that you'd look at. Decreased cardiac output, risk for ineffective tissue, cardiac tissue perfusion, acute pain, and there would be anxiety. So those would be things that we would look at first. Also, incorporating the purpose of and nursing responsibilities for the diagnostic tests, lab values, pharmacological management into the care of the patient with dysrhythmias. Lab pops up and says, hey, don't forget us, serum electrolytes like potassium, calcium. We'll talk about the difference between calcium and free calcium, like ionized calcium, magnesium, and glucose. The little symbol there shows the heart. It looks like less than and 3, but that's actually a little texting heart symbol. So heart monitor, electrode placement we'll talk about, and then we'll talk about medications for too fast from top part of the heart, too fast from bottom part of the heart, too slow, and dead. And you can see some of the other, in that left column, you can kind of see, okay, ECG electrode placement we'll talk about checking labs. We'll talk about what's on a basic metabolic panel, which is a common panel that we check for electrolytes, and what's not. Then we'll talk about the drugs. Okay, further objectives, evaluating the effectiveness of the care, patient teaching. And that includes risk factor modification, what do they need to change, electrolyte recommendation, pharmacological management to promote and maintain health. We're not just talking about the interventions, but we want to also evaluate those interventions and say, has this been effective? Has this worked for the patient? Will the patient leave here and not get in the same difficulty again? Those are the questions we'd ask to evaluate. We'd evaluate the effectiveness of communication and documentation, because if you cannot document that, that's how you share what's going on later. So if you got in a lawsuit and 5 years later somebody said, hey, did you take care of this patient that had this dysrhythmia that died? And you're like, I don't remember that. Well, let's look at your documentation. Oh, okay, yes, I did do these interventions. I did evaluate it. It didn't do that. They didn't work that well, but I did notify the doctor or the nurse practitioner or the provider, and they gave me orders, and this is what we did next. Well, if I have that documentation, that's great. If I don't, then that's sad, because you could be liable for some situation. The effectiveness of that communication also has to do with, can you get the point across to the patient at the patient's level? So you just can't just have the knowledge, you also have to connect with the patient. So that helps with decision making, error prevention, care coordination, all of that is based on good communication. Utilizing assessment findings to prioritize and delegate care. If I could do one thing for the patient and then leave, which would be the safest for the patient, which would help the patient, which answers the question on our NCLEX style questions, which one answers the question? Incorporate CUSIN competencies into clinical practice, the safe and competent care and best practices. Okay, well, this talks about the leads and shows kind of the leads placement if you had a 3-lead a monitor, or if you have a 5-lead monitor. Most modern monitors will have 5 leads. Many, sometimes portable ones will only have the 3-lead, or defibrillators will only may have the 3-lead, but most of the ones you'll see in the hospital setting will have 5 leads. And so you can see this. We used to always say white to right shoulder, red to ribs, and what's left over, the black lead, goes over the left shoulder. So if you got those 3 basic things down, white to right, red to ribs, what's left over goes over the left shoulder, then we would add for the other 2 the other little saying, clouds over grass or white over green. So below the white one where you've already placed it, you place the green one, and then smoke over fire, where you take the red and the black leads we've already placed, and then brown would be in the middle. So that would be kind of an old, that's how paramedics used to say. Sometimes nurses will say that, and you'll see that kind of saying to remember, where can we put these on? Because when you're putting these on, you're generally doing it in an admission, so you're wanting to do it quickly. Most of the electrodes are labeled. We'll say LL for left limb lead, or lower leg lead, or right limb lead. So you would know where to place them because of that, but this would be a saying that helps you do that quicker and know where to do that in an emergency situation. Okay, this has a lot of information, but on our strips that we're going to do, we're going to get a strip out, and it's going to have these P, QRS, T complexes on them. And so we're going to explain what that is. But first of all, I just want to realize that the heart has an electrical conduction and then a mechanical conduction, much like a car. Like you turn your alternator on, and electricity goes to the battery, and then it makes the physical turning over of the motor, and those the car actually start and run. So you have an electrical component and you have a mechanical component. Same with the heart. You have an SA node that begins the pacemaking. And we call it the pacemaker of the heart because it generally starts the electrical process, and it moves to the AV node, atrioventricular node. So that SA node to the AV node is from the top part down to the bottom part of the heart. And on the bottom part of the heart at the bundle of His, we'll see it separated up into the left bundle branch and right bundle branch. As long as there's nothing bad going on with the heart, we generally see that as one thing that shows up on the on your monitor, and that's the QRS complex. And you see the Purkinje fibers and the firing and all of that. So Our P wave represents the top part of our heart. Our QRS represents the bottom part of our heart, firing or depolarizing. And then the T wave represents the repolarization of the bottom part of the heart. My daughter used to come up to me and come up and hug me, and I'd say, "Hey, do you love me this much?" And I'd show my hands real little. And she'd say, "No, Daddy." And I'd raise them a little bit further and say, "Do you love me this much?" And she'd say, "No, Daddy." I said, "Do you love me this much?" So my arms way stretched out, and she goes, "Yes, I do." And she gave me a big hug. Well, I want to kind of get this down here with you. The top part of our heart, our P wave, that represents, and the PR interval from that distance from the top to the bottom part of the heart, we have a little bit of love for it, but it's not going to kill us if we lose the top part of the heart or our atria. The ventricles, we have a lot of love for, because if we lose those, we lose the major pumps. One pumping to get oxygenated from the right side to the left side, and then from the left side goes to the heart and the brain first. The two organs that it perfuses first are key to our survival. Does that make sense? So, right. Okay. So what do you think is, of these symbols on here, do you think the P, the QRS, or the T wave is most important to have on there? That's right, the QRS complex is the most important, because that represents the depolarization of the ventricles. You lose the atria, you lose about 15% of your cardiac output. You lose the ventricles, you lose 85% of your cardiac output. So which am I going to choose here? I'm going to choose the, that's right, 85%. Right, good, the ventricles. Good job. So when we talk about these markings here, we'll see first an isometric line. That's a solid line. That's kind of our baseline. And it's going to kind of say where everything returns to and where we go. When we first start to see our P wave go up, you see that it thins a little bit from the thicker isometric line. It starts to go up a little bit and forms the P wave. And that's the depolarization of the atria, or the atria getting ready to fire and contract. And so we will look at the P wave, we look and say, oh, that's great. So then we will measure a PR interval in these little boxes. Each of these little tiny boxes is 0.04 seconds. So 0.04, 0.08, 0.12, 0.16. So this PR interval is 0.16. And so if it goes 5 boxes, then we're starting to get a little worried that that distance from the SA node to the AV node is being prolonged with something. Something bad's happened, patient's had a heart attack, some disruption, electrolytes are off, something's going on, but it's prolonging that PR interval. So we always will measure the PR interval, beginning of the P wave to the beginning of the QRS complex. We see our QRS complex, the first wave that goes down is the Q wave. Now, not all patients will have a Q wave, but so we will kind of technically say it's a QRS complex, even though it may just start and go up. It may be at the isometric line and go up to the R wave and QR and back down to the S wave. If it technically, if it doesn't go below the line, it's not a Q wave, but we're going to call this a QRS complex, a QRS complex. And we're going to measure the distance, the width of that. How big is that? Is that more than 3 boxes? And so our gang signs are, we take your hand, take 5 fingers on your hand, and you go, put it from the top part of your heart to the bottom part of your heart. It's no more than 5 boxes. So I need to see you doing that. Come on, put your hand on your chest. It's okay. Nobody's watching. Okay. Good, good. And then take your 3 fingers and give me some love by hitting that to the bottom part of your heart. So throw me kind of a gang sign. 3. Come on. It's all right. Come on. You can do it. Come on. Okay. Good. So 3, no more than 3 boxes in its width. And then the other thing that we measure is the QT interval. A lot of medications that patients will have, especially in mental health, will prolong the QT interval. So we have to be careful of that. So we measure from the beginning of the Q wave to the end of the T wave, and it should be no more than 10 of the little tiny boxes, or 0.40. And so we'll put all that together. I mean, if you don't get that down, that's okay. We'll get that down in a second. And we'll put it back and we'll look at the strips, and we'll look at the strips data later. I just wanted you to get the conduction down and kind of see what the normals are. Okay, which lead is best? Lead 1 pops up and says, hey, I'm best because I go from left to right and I show the QRS upright. So in different leads on the monitor, you would choose the dial and you'd say dial over to lead 1, lead 2, lead 3, MCL1, patches, paddles, whatever. It will default to paddles when you first come on unless the patches are plugged in, then it'll default to patches. And then it would say, hey, it'll show up that way. Well, rhythms should follow a certain pattern. They should be upright with the QRS in certain leads, and in other leads they should be facing down. So we want to make sure the leads are placed on correctly, like white to right, red to ribs, what's left over goes to the left shoulder, and clouds over grass. And then the brown one in the middle, we want to make sure all of that's correct, because if we have a rhythm that doesn't look correctly and it's in the right lead, we're going to say, hey, something's really happened to this patient, versus it just being somebody, hey, I just have a person in the wrong lead, or I don't have the electrodes on correctly. So lead 1, again, the QRS isn't that prominent, but it is upright. Lead 2 pops up and says, hey, I'm the best because I go from left to right and show the QRS upright, most like the normal conduction of the heart. So we give that a thumbs up because that's our normal rhythm that we would want to monitor patients in as lead 2. If we have no other lead to do it, we'd like to do it in lead 2. It's not uncommon to have a secondary lead, maybe like MCL1, that shows us another view of the heart, but our main one should be lead 2. Lead 3 is best. It pops up and says, I go from left upper to left lower, and it shows QRS upright. Well, yeah, that's nice, but again, lead 2 we would still want to be our kind of default lead. MCL1, or sometimes they might be called different V leads, it says it's best because it's coming from left to right side, which is opposite the conduction, and so you see the QRS is now facing down. But it is good to see abnormal rhythms, so like maybe I can see PVCs or other things, and so lead 2 and MCL1 would be 2 good leads to have on there. But if I had to have one lead, which would I choose? That's right, the lead 2, because it most follows the conduction of the heart. Oh, chemistry. Chemistry, my dear chemistry. I loved chemistry in high school. My teacher would do things and we'd get hands-on stuff, and I loved it. I just fell in love with this because in nursing it's so applicable. You know, your nutrition, you take in electrolytes and all of this, but I'll try and maybe just simplify this. So you guys probably have heard of the sodium-potassium pump. And so if you look on the periodic table, you see these salts over here. You have sodium number 11, potassium's down here number 19, and they're usually bound to, these are plus ones, and they're usually bound to the ones over here on the right side where like chloride, so you have potassium chloride, calcium chloride, those kind of things. And that's not that would be common thing because they have plus one and these have negative one, and so they tend to bind together a lot. But our main, if we're talking about different perspectives, our main perspective inside the cell, what is our main intracellular ion inside the cell? And that's potassium. And what's our main extracellular ion, or in the vessel? And that's sodium. Well, what happens here in the cardiac tissue is we have what they call an action potential that forms when we have this rapid exchange of sodium and potassium. And we have more sodiums, 3 sodiums going into the vessel, and 2 potassiums going into the cell, and it leaves this imbalance, but it creates energy, electricity, and this is our main stimulus that starts the potential for our heart to actually beat. So we have this electrical conduction starting with this sodium-potassium pump. So there's a few jokes here on the side you can kind of look and read as you want to. Don't trust atoms, they make everything up. Anyone know any jokes about sodium? Nah, well, that's the symbol for sodium, get it? Silver Surfer and Iron Man team up, they'd be alloys. Okay, doesn't really apply to this. Why do chemists like nitrates so much? They're cheaper than day rates. Well, nitrates do apply to this because patients having heart attacks many times will get nitrates. So anyway, I just wanted to throw a little humor in there. I know we don't want to do too much of that, but I know. It's okay. You can stop laughing. No, it's okay. It's okay. Okay. We'll move on now. Okay. So we'll talk about, so it would be good for you guys to automatically just learn and know, memorize your electrolytes and what your normal ranges are. So sodium, 135 to 145. A lot of times you'll see this 35 to 45, 3.5 to 5, that kind of numbers were being repeated. And so some of those you might say, hey, I kind of remember that from this or from that. And so it's not that hard to memorize them if you kind of remember some of those numbers being common. But sodium, the normal range is 135 to 145. Your body can handle a little bit of the sodium being out of range, low or high, but if it gets too low or too high, which we kind of talked about when we did the central line lecture on fluid and electrolytes, but if it gets too low or too high, you can have problems with your electricity in your heart and your neurological system. So if it's very low, many times you'll see seizures and we'll replace the sodium if it's too low. If it's generally too high, we give generally water, free water, to kind of dilute that down a little bit. So we'll talk about potassium a little bit. Potassium is kind of one of your main electrolytes for your heart. So potassium, magnesium, and calcium, specifically ionized calcium, are the three kind of big ones. So your heart really doesn't like having potassium out of range. If it's elevated, your heart rate will decrease, you have bradyarrhythmias. How does, when you take a dog and have them put to sleep, how do they euthanize the dog? They give them IV potassium, and it stops the heart. In the heart surgery, what do? They give IV potassium that stops the heart. When Kevorkian was doing his assisted suicides when he was alive, he would use IV potassium. So that's something that we want to have a lot of caution for and be very careful that if it's out of range, we want to do something about it right away. So that would be a priority, prioritization. We kind of talked about that, say, hey, priority here to get this corrected. So you might see it showing up as different arrhythmias. If it's too low, again, you're going to have tachyarrhythmias. So too high, brady, too low, we're going to have tachy. So it's kind of opposite there. Hypokalemia can be caused by severe diarrhea, vomiting, urination, or excessive insulin intake. So fatigue, weakness, muscle changes in heart function, especially these tachyarrhythmias. So increase in heart rate and arrhythmias that way. So this is part of this sodium potassium pump. We need both of those, but if they're out of range, it can be causing problems. So if you have a dysrhythmia on the monitor, what's one of the things you should look at? Lab values. That's correct. Good job. And one thing at the top here in the corner, it says, this is how labs will be labeled in many charts. I know medical the medical side of things, and other health teams sometimes use this. So you'll see not white blood count and hemoglobin, hematocrit, platelets will not be written in there, but the numbers will. And you have to know, oh, they're referring to white count, they're referring to hemoglobin, hematocrit, and they're referring to the platelets. And so then the bottom one would be our electrolytes. So you might see 137 over 3.7 and 91 chloride and 22 CO2 and BUN 0.8. Or I mean, BUN would be like, I don't know, probably 30, and creatinine would be 0.8. Glucose, I don't know, 97. Calcium 10, albumin 1.5. So those would be things you just see written out, and you have to know, oh, that's sodium, that's potassium. So you might kind of get to know that format so that if you see it written, you'd be ready for it. Now on the left side, we kind of talk about what's in a basic metabolic panel. This is commonly ordered when a patient comes into the hospital, just to kind of get some baseline information, usually CBC would be ordered in a basic metabolic panel. The two common things. CBC is looking at bleeding and clotting and infection, and basic metabolic panel is looking at electrolytes. So what's not on a BMP is magnesium, phosphorus, albumin. So you may have to advocate for those to be done if you're suspecting maybe patients having an arrhythmia and you have potassium level and a calcium level, but you don't have a magnesium, phosphorus, albumin, you may have to advocate that those be drawn or run on the blood in the lab. And just a reminder, sodium is your main electrolyte in the vessels or extracellular ion, and potassium is the main electrolyte inside the cells. So, okay, what we see here is calcium and albumin. And so one thing you see on the left side here is how does the muscle actually work in the heart. So it's striated cardiac muscle, and calcium is regulated by the parathyroid hormone in your thyroid gland. There's two little kind of circular glands there, and they release calcium. And ionized calcium is the free calcium. And then some calcium, about 50 to 60% of it, is bound to albumin. Well, if you think your heart muscle is made up of proteins, and those proteins are made out of albumin, your calcium is binding to that. So you have to have free calcium available so they can go into these calcium channels and then bind, and then as the heart contracts and you stretch and stuff, the calcium has to be available to do that. So when we check a calcium level, we don't really know whether the calcium's low unless we know what the albumin level is. So I can have a calcium that's 8, which would be technically low, but I could have an albumin that's 1.5, and you'd say, well, it's just because the patient is malnourished, and so they don't need more calcium, they just need more food. They need to be fed, get some protein in them. So what I'm going to look at here is the calcium that's bound to albumin. If you call the doctor and say, hey, my calcium's low, what do they think they're going to ask for? That's right, they're going to say, what's the albumin level? And you say, well, we haven't run that yet. So you could get an ionized calcium. So before you call your doctor, you have a calcium level, see if the albumin's been drawn. If not, then advocate for an ionized calcium to be drawn so you know what the free calcium is. So you know if the patient really is low in calcium. And then this just talks about the low result, what happens if they're low and what happens if they're high. So inadequate calcium intake or the patient's being restricted for some reason, they dialysis patient, something like that. So you want to look at that. Is it too high calcium? So calcium containing phosphate binders, or could be a patient has neoplasms that are malignant. So high calcium can cause a wide variety of symptoms, so weakness, vomiting, irritability. So that's pretty vague and general to a lot of symptoms, to a lot of disease process. So you have to really figure out what's going on here and put your kind of assessment hat on and say, okay, I got to get down to high calcium. What's going on in this patient's life? Low calcium may be more likely in the hospital. Maybe inadequate intake has been going on. Albumin, 3.5 to 5. Again, you see that number, the exact same as the potassium value. So if you memorize the potassium, then you know your albumin is exactly the same. So your albumin's, if it's low, and almost all the time you see in the hospital, you'll see a low albumin because patients aren't being fed. So we got to get the gut fed. We've got to get the patient fed as soon as we can. That's key because the albumin is what holds everything into the vessel. So this is kind of what we'll talk about as we kind of go along here. Have we looked at the electrolytes? Okay, and then magnesium, we'll talk about it at 1.5 to 2.5, very low numbers, but it's not typically on the on a basic metabolic panel, so you will have to advocate for a magnesium level or a phosphate level or a phosphorus level if you want to know those. And so it's needed in the neuromuscular activity or the cell stimulation. So electricity can cause the action potential, and then you have your beat of your heart. So it's found inside the cells, much like potassium. So low magnesium, malnutrition, malabsorption, should have adequate, as long as you have a normal diet, should have an adequate intake of magnesium. If it's high, severe dehydration, renal failure, antacids, laxatives. So that's something that's maybe common. People may utilize them. Just be careful of how frequently they're utilizing them or what's in those brands themselves. So typically you replace magnesium slowly for best absorption. 1 gram over 1 hour or longer is your typical way you would do that. Many times you see more and more running over 3 and 4 hours or 5 hours so that it's better absorbed in the body. It's not just put in and then utilized or used up. You want to read more about the contraction of the heart, I suggest you look at, they got this new thing called Google. I don't know if you ever heard of it, but you can look stuff up. And you can read about Frank Starling's law. It talks about the stretch and the contraction. The more you pull, the more your heart pulls or stretches to contract, the harder the contraction up to a point. So that kind of that's kind of interesting. It's a physics principle. You might want to look at it if you want more in-depth kind of understanding of what's going on with that. So